In this lecture, we'll be discussing about spring catarrh. Now, the definition: spring catarrh or vernal keratoconjunctivitis. It is a recurrent, self-limiting inflammation of the conjunctiva having periodic seasonal incidents. Okay, so you can basically remember this as allergy of the conjunctiva. Okay, so there is again recurrent, self-limiting inflammation of the conjunctiva having periodic incidents. Now, let us look into the etiology. Now, VKC, it is common in individuals with predisposed atopic background. Okay, so atopic background, and other predisposing factors are age, 4 to 20 years, sex, it is more common in males than in females, season, it is more common during the summer, and there is family history of VKC. So this is the definition and the etiology. Now let us look into the pathology of VKC. Now the layers of the conjunctiva are the epithelium, the adenoid layer, and the fibrous layer. So let us look into the changes in each of these layers, the pathological changes in each of these layers in vernal keratoconjunctivitis. Now the conjunctival epithelium, it contains large number of mast cells, eosinophils, and it undergoes hyperplasia. So remember, this is VKC is similar to allergy. Okay, so hence there is large numbers of mast cells, eosinophils, and the conjunctival epithelium undergoes hyperplasia. Now the adenoid layer, it shows marked infiltration by mast cells, eosinophils, plasma cells, and lymphocytes. The fibrous layer, it shows proliferation which later undergoes hyalinization, and the conjunctival vessels show proliferation and vasodilation. Okay, so the basic pathological changes are infiltration by the cells that respond to allergy, that is mast cells and eosinophils. Okay, now moving on to the clinical features. So we have the symptoms and the signs. Now the symptoms of VKC or spring catarrh are: number 1, there is marked burning and itching sensation which is more severe during warm and humid conditions. Okay, so remember, it is basically allergy. So there is marked burning and itching sensation which is more severe in warm and humid conditions. That is why there is the name spring catarrh, that it is more common during the spring or summer. The second clinical feature is the presence of lacrimation. Then we have mild photophobia, stingy discharge may be present, and heaviness of the lids due to the presence of papillae. So again, the symptoms are: the important one is marked burning and itching sensation which is more severe during warm and humid conditions. Second is lacrimation, mild photophobia, stingy discharge, and heaviness of the lids. Now before we discuss the signs, remember this is vernal keratoconjunctivitis. Keratoconjunctivitis meaning it can affect both the cornea and the conjunctiva. And the conjunctiva, as we know, has two parts: the palpebral part and the bulbar part. Okay, so we can divide the signs. We can divide VKC as palpebral form, bulbar limbal form, and the vernal keratopathy. Now let us look into the palpebral form first. Now here the upper tarsal conjunctiva, it is usually involved, and it shows the presence of the following: that is hard, flat topped papillae arranged in a cobblestone or pavement stone fashion. So you can see in this diagram, this is the palpebral conjunctiva, and it shows the presence of papillae arranged in a cobblestone fashion. And this is the clinical picture showing papillae in the cobblestone arrangement. Then the second feature is the presence of conjunctival hyperemia. In severe cases, the papillae may show hypertrophy, and it produces cauliflower-like projections. So again, the palpebral form, the upper tarsal conjunctiva, it shows the presence of hard, flat-topped papillae arranged in cobblestone or pavement stone fashion. Conjunctival hyperemia may be there, and in severe forms, the hypertrophy of the papilla leads to the formation of cauliflower-like projections. So this is about the palpebral form. Remember, papillae in cobblestone fashion. Second is the bulbar limbal form, which predominantly affects the bulbar conjunctiva. Now here there is presence of dusky red triangular congestion of the bulbar conjunctiva in the palpebral area. Second is the presence of limbal papillae. Now the limbal papillae, it is a gelatinous, thick and confluent accumulation of tissues around the limbus. And the third feature is the presence of Horner Tranter spots, which are whitish raised dots along the limbus. So again, if you look into this diagram, in the bulbar limbal form we have the dusky red triangular congestion. Then we have the presence of limbal papillae, that is gelatinous thickening of the gelatinous accumulation of the tissues in the limbus area. So this is the limbal papillae. And the third feature is the presence of whitish raised dots around the limbus, and these are known as the Horner-Tranter spots. So again, remember, in bulbar conjunctiva there is dusky red triangular congestion, then there is presence of limbal papillae, and finally presence of Horner-Tranter spots. The third is the mixed form of VKC, where there is combined features of both the palpebral and the bulbar limbal form of vernal keratoconjunctivitis. And the fourth is the vernal keratopathy, that is the disease, it affects the cornea as well. Now, the important features of vernal keratopathy are: there may be presence of punctate epithelial keratitis. Second is the presence of epithelial erosions. Third is the presence of vernal corneal plaques. Now, because of the erosion, there is presence of erosions, and due to coating of the erosions by exudates, we get a vernal corneal plaque, as you can see in this diagram here. Okay, so this is the there is a corneal erosion, and when there is accumulation of exudates within the erosion, it leads to the formation of a vernal corneal plaque. Fourth is the shield ulceration, and now this presents as a shallow ulcer in the upper part of the cornea due to epithelial erosions. So this here shows the shield erosions. Fifth is there may be subepithelial scarring, and the sixth feature is the presence of a pseudogerantoxon. Okay, now if you look into this diagram, it is pseudogerantoxon, meaning pseudo meaning false, gerantoxon meaning arcus annulus. Now it is a lesion that resembles the arcus annulus, as you can see in this diagram here. So again, the important signs, let us revise. Now the signs: vernal keratoconjunctivitis, so it can be divided as the palpebral form, the bulbar form, and the vernal keratopathy. Now under palpebral form, the important feature is the presence of papilla, which are arranged in a cobblestone fashion. Okay, then there is conjunctival hyperemia, and if there is hypertrophy of the papilla, it leads to cauliflower like projections. Now, in the important features of the bulbar limbal form is the presence of dusky red triangular congestion, presence of limbal papilla, and finally the presence of Horner-Tranter spots. And then we discuss the mixed form, where there is combined features of both the bulbar form and the palpebral form. And finally we discuss the vernal keratopathy, and the important features under vernal keratopathy is the presence of vernal corneal plaques and the shield ulcer. Okay, now let us again revise the diagrams. So this shows the presence of cobblestone papillae, the presence of dusky red congestion, presence of Horner-Tranter spots. This is the clinical picture showing the presence of limbal papillae. Remember, it is a gelatinous accumulation of tissues around the limbus. This shows the Horner-Tranter spots, that is the whitish raised dots seen in the limbus. This shows the epithelial, the vernal corneal plaque due to the accumulation of exudates within the corneal erosions. This is a shield ulcer, which is a shadow ulcer seen in severe form of VKC, and this is the pseudogerantoxon, which is a lesion resembling the arcus annulus. Now the differential diagnosis of the VKC are: number 1, trachoma, and number 2, atopic keratoconjunctivitis. Now let us look how we can differentiate between VKC and atopic keratoconjunctivitis. Now VKC we have discussed in the etiology that it affects children between 4 to 20 years. So age, it is commonly in the younger population, whereas AKC is more common in the older populations. We've discussed that males are more prone to VKC, but there is no predilection for AKC. Disease is more it is limited, whereas in atopic keratoconjunctivitis it is chronic. Time of the year, spring or summer, and AKC is perennial. Conjunctival involvement, the upper tarsus is most commonly involved. Remember the features we've discussed, that is presence of papilla arranged in cobblestone fashion, whereas in AKC it is seen in the lower tarsus. Cornea shows presence of shield ulcer, whereas shield ulcer is absent in AKC. Corneal scar is common, but it is not vision threatening, whereas in AKC it is the scars are vision threatening. And the conjunctival vascularization is rare in VKC, whereas it is common in AKC. So important ones we can remember from our discussion of VKC are age, sex, duration of the disease. We've discussed that it is a self-limiting disease. Then the time of year, conjunctival involvement, and the corneal involvement. So the important differential diagnoses are trachoma and atopic keratoconjunctivitis. Now let us move on and discuss the treatment of vernal keratoconjunctivitis. Now we've discussed that this is an allergic process, so we have to give topical anti-inflammatory therapy. Now the various drugs that can be used for treatment of vernal keratoconjunctivitis are most importantly topical steroids. Now the most safest steroids that can be used are fluoromethalone and medrysone. Now the others like dexamethasone and betamethasone are not commonly used because there is the risk of steroid induced glaucoma. So remember, the first is topical steroids, fluoromethalone and medrysone. Second is the use of mast cell stabilizers like sodium chromoglycolate, which is given as a 2% solution to be applied 5 times a day. Third is the use of antihistamines like azilastine, which is used to prevent exacerbations. Then non-steroidal anti-inflammatory drug eye drops like ketorolac or diclofenac. Topical cyclosporin, which is an immunosuppressive agent, 0.5 to 1% solution can be used when steroids are ineffective. And tacrolimus is another immune modulating drug, and it is given as an ointment, 0.03%. So again, the topical inflammatory therapy, remember we're trying to suppress the allergy, so we can give topical steroids. Now here the important steroids to be given are fluoromethalone and medrysone. Second is the use of mast cell stabilizers like sodium chromoglycolate. Third is the use of antihistamines, azilastine. NSAID eye drops like ketorolac and diclofenac. Fifth is the topical cyclosporin and tacrolimus, which are both immunosuppressive agents. Now the second mode of treatment is the use of topical lubricating agents and mucolytics. Here artificial tears like carboxymethylcellulose can be given, and the second is acetylcysteine, which is useful in the treatment of early plaque formation, that is as a mucolytic. The next mode of treatment is the use of systemic therapy, where we use oral antihistamines and oral steroids to suppress the allergy. Next is the treatment of large papillae. It requires surgical excision or supratarsal injection of long-acting steroids. Then we can give supportive measures like dark goggles and cold compress. Desensitization is another medical therapy that is not often used now. And finally, we have to treat vernal keratopathy, punctate epithelial keratitis, steroid can be given. If there is vernal plaques, surgical excision can be done, and for shield ulcers, superficial keratectomy can be done. So again, the treatment is important. There is use of topical anti-inflammatory drugs. The important ones are topical steroids like fluoromethalone and medrysone. Then mast cell stabilizers like sodium chromoglycolate 2% solution, antihistamines like azilastine, and non-steroidal anti-inflammatory drugs like ketorolac and diclofenac, topical cyclosporin and tacrolimus, which are immunosuppressive agents. Then we give topical lubricating agents like artificial tear and mucolytics like acetylcysteine. Systemic therapy involving the use of oral antihistamines and oral steroids. Treatment of large papillae requires supratarsal injection of long-acting steroids. Surgical excision can be done. Supportive measures, desensitization and vernal keratopathy. And if there are presence of shield ulcers, we give superficial keratectomy. So this sums up our discussion on vernal keratoconjunctivitis. Now let us have a quick revision. We discussed the definition, that is, it is a recurrent self-limiting inflammation of the conjunctiva having periodic seasonal incidents. Basically, remember, allergy of the eye. Next, we discuss the etiology, the pathology, the changes in the 3 layers, and most importantly, there is infiltration by the eosinophils and the mast cells. Clinical features, we discuss the symptoms and signs. The important symptoms is the presence of marked burning and itching sensation, lacrimation, mild photophobia, syndesmosis, and heaviness of lids due to presence of papillae. Then the signs we discussed: the palpable form, the bulbar form, the mixed form, and the vernal keratopathy. Palpable form, the important sign is the presence of papillae arranged in cobblestone fashion. Here we discussed three important signs: dusky red congestion, limbal papillae, and hornet under spots. Then we discuss the mixed form and vernal keratopathy. Under this, the important features to be remembered are the presence of vernal plaques, shield ulcer, and pseudogerontoxon. So this is about the signs. The differential diagnosis is trachoma and atopic keratoconjunctivitis. And treatment modality we've discussed in detail, and the most important is the use of topical anti-inflammatory therapy. Now, a simple mnemonic to remember the treatment of spring catarrh is just remember spring catarrh. Now, the important letters are S, I, A, and H. Now, S stands for topical steroids like fluoromethalone and metrisone, and along with steroids, just remember non-steroidal anti-inflammatory drugs like diclofenac and ketorolac. Now, S stands for sodium chromoglycolate, which is the the mast cell stabilizer. Now, I stands for immunosuppressive agents like cyclosporin and tacrolimus. A for artificial tears, and the second is acetylcysteine, which is the mucolytic, and H for antihistamines, that is azilastine. So this is the mnemonic: spring catarrh. S for topical steroids, non-steroidal anti-inflammatory drugs are sodium chromoglycate. I for immunosuppressive agents, that is cyclosporin and tacrolimus. A for artificial tear and acetylcysteine, that is the mucolytic, and H for antihistamines, azilastine.